Thank you very much. My name is Barry Northedge. I live in Scotland. I'm part of the National Dementia Carers Action Network in Scotland, and I'm also part of the European Dementia Carers Working Group. And I'm really pleased that you stuck it out and we're on the last lap and you're here supporting the presenters that we're going to see in the next hour or so. So thanks very much for that. Residential care is something that's very personal to me, as my father-in-law went into residential care last August, and it never really suited him. And there were good and the bad aspects about the care that he received, but he died on December the 4th. And so it's a topic that is very, very close to me. And I think we need to focus on how we can improve the conditions and how people with dementia in residential care are treated and supported and valued. So my speakers today are going to take you through that. And obviously, there's going to be lots of good information here. So I'd like to hand over, first of all, to Stefanie Wiloth, who's going to talk about verbal feedback and nursing development. Guten Tag.
Guten Tag und danke. Hyvää päivää. Yeah, thank you very much. Thank you very much for the friendly introduction, so I have to coordinate. All right. So, yes, it's a very great pleasure to share in the next 12 minutes. I hope you can see the importance of verbal feedback and nursing skill development to promote quality of life in people with dementia. First of all, of course, I want to give you a very short theoretical background, and I would like to start with the question, what does professional nursing practice, what does caring for people with dementia mean? And of course, we all know that it means to maintain quality of life, despite all impairments which can occur in the context of dementia. But I think we have to focus on the subject dimension of quality of life. And so I think we have to focus on the social environment. So when we are talking about what is professional nursing, what is caring for people with dementia, a professional caregiver has to ask, of course, how can people with dementia perceive their social environment? How can they react on the social environment? And in particular, we have to ask, how can people with dementia create their social environment in a self-determined way, of course? So this is linked to, you know it all, to the perception and realization of psychosocial needs of people with dementia. This is the task. So, of course, a professional caregiver has the task to create social contexts in which people with dementia experience sympathetic, trust, connectiveness, attendance, and so on. But to do that, to create social context, to meet the psychosocial needs of people with dementia, it requires a high level of nursing skill competence to be developed. And to achieve a high level of nursing skills, nursing competence, I think, of course, you have to be a very broad theoretical background. It is necessary, but also, of course, practical experience. Sometimes we see in several studies that there is a very big mismatch between theoretical knowledge, I know what psychosocial needs of people with dementia are, and the practice, or you can say the realization of my knowledge in the context of caregiving. Because, yes, due to time constraints, of course, and very complex demands in the context of professional caregiving. So we have to ask, how can a professional caregiver identify this mismatch? And the answer is, I think, that it's necessary to implement work-based education and learning processes in the context of professional care, which aims especially to facilitate self-reflection. Self-reflection helps to identify this mismatch between theoretical knowledge and practice. It helps to create a new perspective on the own actions and behavior, of course on the behaviors of the residents with dementia too, and on the complex care situation. And of course, when I, as a professional caregiver, identify the mismatch, I say, yes, I know very much about, but did I do in the practical work? I don't know. I identify this mismatch, and then I'm very motivated to close this gap, of course, so I will change my behavior. I will do it better in the future. However, sometimes it's very hard for professional caregivers to reflect on their own behavior because, for example, due to time constraints. But there are methods, for example, peer review approaches, which can help, let's say, which can push in the direction to self-reflection, which can give an opportunity to do it. And peer review approaches are, you can say, a kind of peer conversation where colleagues, professional caregivers, can give verbal feedback to each other, constructive feedback. And of course, such approaches have to be very inexpensive in the context of long-term care, effective, of course, but they have to be easy to implement to do it. And they have to enable, first of all, the observation and documentation of caring situations, for example, of morning care situations, because you have to focus, for example, on the quality of interaction between a colleague and the resident with dementia. And peer review approaches have to enable constructive feedback in collegial communication based on the measurement results, based on the results of a collegial observation, you can say. And then it can help to push this self-reflection and, you can say, social learning processes, work-based social learning processes. Yes. For this purpose, we have developed, together with the Federal Medical Service in Germany, the Hilde QS instrument. Unfortunately, it is here in German. I will translate. It is the Heidelberger instrument to assess quality of life in people with dementia for quality insurance in long-term care or nursing homes. Yes, and what is the aim of this instrument? Oops, I was very fast, I'm sorry. Hilde QS is an instrument which asks, first of all, how is the message communicated for people with dementia to understand? So first of all, we have to ask what behaviors is the resident with dementia confronted with? So the first aim of the instrument is to evaluate the caregiver's behavior. Communication patterns, especially at two levels, the relationship level and the action level. Relationship level is behavior which promotes social interaction. Negative example is baby talk. And the action level is, for example, hard instructions. So stand up, brush your teeth, brush your hair, and so on. That's the first part. But Hilde QS also asks what messages are sent in response non-verbally by people with dementia. So it focuses on the question, what reactions, facial expressions, gestures does the residents show? So the second aim of this peer review approach is to evaluate, of course, the emotional expression in people with dementia. So when you use Hilde QS in the context of long-term care, you have to be aware of both the behavior of the resident, when you're the observer, the behavior of the resident, and the behavior of your colleague. And you have to evaluate, you can say, the quality of interaction between both of them. And that brings me to the elements of Hilde QS, of the instrument. The instrument consists of two main elements. The first element is the documentation tool. It is a kind of observation tool, documentation template. You can see it here, unfortunately in German, but I will translate. You have to imagine, you are a professional caregiver, you have to enter a very complex care situation, for example, morning care, with this template and paper pencil, for example, or tablet, or what else. And then you have to observe the interaction between your colleague and the resident. And here you can see an example. It's very simplified. You have on the left side the emotional expressions a resident could show, for example, well-being, insecureness, fear, sadness, anger, or pain. And you can see here that at the beginning of a caring situation, the observer identified, for example, I can say it now. For example, insecureness, it's the first cross on the left side, insecureness. But he also identified some trigger factors that leads to these emotional expressions. Here, in this example, the fact that an unknown person enters the room. So a caregiver understands a very complex situation much more better and understands something about the quality of their interaction. It's a very simplified example, as I said. The second element of the instrument, and that's a very important element, is the feedback interview, of course, because it's about feedback today. So we have developed a self-reflection guide for caregivers, and they can use it. They can enter a dialogue with the observed caregiver, with a colleague, and give feedback. The first part is that the observed caregiver should have the opportunity to describe the care situation from his or her point of view. It's very important. So the observer can ask, for example, what did you do particularly well from your point of view? What was negatively? What would you differently, or how would you differently behave next time? And the second part is, of course, the observer have to give constructive feedback. At the end, there is a kind of discussion between both, and they have to find a conclusion. For example, they are discussing about what can we do now, what were possible interventions to make your behavior better, and so on. That's very, very important. Yes, we have evaluated these two main elements in a follow-up study. We have recruited 15 professional caregivers from 21 care facilities in Germany, and they participated in a 2-day training to become a so-called HildeQS representative. A representative has the task to implement HildeQS in their own facility, and of course to conduct the observation of the caring situations. We included 79 people with moderate to severe dementia. They have to observe the emotionality and the communication patterns of the colleague. Of course, they have to conduct the guided-based feedback interview with the colleague. And afterwards, they repeated the observation of the same care situation with the same resident with dementia, of course, to evaluate effectiveness of the feedback together with the colleague. They sent the results and documentations to us at the Institute of Gerontology in Heidelberg, and we have the task to comprehensively analyze it using statistical analysis, of course. And some results I want to present. The first results are the changes in the care behavior, so the changes of communication patterns of the observed caregiver. You can see here positive and negative communication patterns of the caregiver at the both levels. Light gray and gray is the level of relationship, and red the action level, hard instructions, and so on. And of course, before and after the feedback interview, and you can see here, we were very proud of that, that all behavioral communication patterns significantly changed in a positive way. We have a significant decrease of negative communication patterns of the caregiver and a significant increase of positive communication patterns. And of course, we thought that it might lead to another emotionality of the resident, because when behavior changed, resident will be changed his emotions also in terms of person-centered care and promoting quality of life. And yes, so we analyzed that. You can see here the positive and negative emotions of the resident with dementia also before and after the interview. And you can see here gray, it's the total care situation. Positive and negative emotions, and red is the beginning, the course, and the end of the care situation. We have decided that. You can see that especially the negative emotions significantly decreased at the course and the end of morning care situations. Yes, all right, so main results. If you have any question to other results, you can write me an email, of course. Lessons learned from this. Yes, it's a conclusion. The study succeeded in demonstrating the positive efficiency of an easy-to-implement peer review process was very easy to implement, on the caregiver sensitivity and interaction quality, and that is, I think, the key criterion for person-centered care in people with dementia or for people with dementia. So thank you very much for your attention. Thank you.
Okay. Thank you very much. Are there any questions for Stefanie before I let her get off the stage?
Thank you.
Yes, thank you for this wonderful presentation. Your conclusion was that it was easy to implement. How did you do that?
Yes.
Because I think it's very hard to give feedback, and it is like a precondition that the team climate is safe to do so.
Yeah.
So
Yeah.
I'm wondering.
Yes, I think easy to implement the implementation of Hilduke-S in the long-term care situation, but it was very challenging to do the 2-day training program. So it's a kind of perspective, what was easy to implement, the training or the instrument, and that was easy to implement because the Hilduke-S representatives, the professional caregivers included in the study, used it really as a paper pencil. It was 1 page, and then they are talking to the colleagues and of course to the leading positions, when can I do it? I have 5 people with dementia, residents with dementia in mind. When can I do it? I will start now. And it was a kind of collegial communication between them, and it was very different from facility to facility when it was implemented, and which people were included. The feedback, so the second part of Hilduke-S was conducted in the breaks, in the coffee breaks, for example, after the morning care situation, sometimes 2 days after the observation. That's possible, so there is no strict standard. You have to say no, feedback is directly after the situation. So it's very flexible and adaptable to implement. So we conducted the focus group after the data collection with all participants, and they told me, no, it's so good that it's adaptable and flexible, and therefore it was easy to implement for them.
Yeah, thank you. And in the training, there was also attention for how to give feedback or to provide feedback.
Yes,
to each
it was a very, very practical training, little theory at the beginning, and then very practical emotion analysis training, feedback training, communication training, and so on. 2 days. Yes,
nice.
Very comprehensive.
Thank you.
There aren't time for any more questions there, but thank you very much for Stefanie. Can I? Our next speaker is Øyvind Kirkevold, and I'm not sure if I pronounced that correctly. My Norwegian's not very good. But Øyvind is going to talk to us about resistance to care and coercive measures.
Thank you. I think I take this one. Yeah. Thank you very much. As I said here, I'm going to speak about a study that was taken on the initiative of the Oslo Municipality Council about resistance to care, mainly, and what happened with a patient in a long-term nursing home when they resist care. And it's a Norwegian National Center for Aging and Health and Center for Medical Ethics in Oslo University that performed this study. But as I said, it was on initiative, and it was paid by the Oslo municipality. And we have a little bit different reason to go in the study. So Aging and Health and Oslo University, yes, I have to press twice here. We had a little bit different reasons. And my reason was to go into this was that if you look back in the history, it was a lot of studies about restraints in the nursing home, and it started with the OBRA Act in US in 1987, I think, and it was a lot of discussion, and it spread around the world, that discussion. And in Norway, we did a study in the year 2000, where we saw that it was a lot of different type of coercive measure, pressure, and so on to perform different kind of care, not only necessarily care, and the most often used restraint was fixation to a chair. And then after a long process in Norway, the legislation was changed in 2009, and it was in practice forbidden to use restraints or other coercive measure with some expectations. Those expectations was that if people lack the capacity to consent, if they resist care, and it was necessary to perform the care to avoid serious health damage or health consequences. And what that serious health consequences is a judgment and not a strict. But we have, and most European countries has some similar legislation, except for Sweden, I think. They have a vision zero, no use of coercive measure or restraints at all. But after the introduction of that legislation, we have different inspection in nursing home, but we have no studies in Norway at all. And we were very interesting to see how the biggest municipality in Norway, how they handled that. So we think that was a very good opportunity to get more knowledge. The Oslo municipality, they discovered, because the legislation said that we could have some legal processes to make a decision that in this situation we have to perform the care even if the person resists. So that legislation that end up in the decision, and they saw that they have much less decisions than expected. And they want to raise the quality of care in the nursing home, and they wonder why is that so few decisions about coercive measure, and what do they do when they don't use coercive measure? So the aim was, and here have a word disappeared, but they wanted to Oslo municipality to see to which extent patients who lack capacity to consent and resist care are subjected to coercive measure. And they also wonder if they not are subjected to coercive measure, are it possible to give necessary care without the use of force or pressure. In this study, we looked at long-term care, not resilience care or not other kinds of short-term care. We went into nursing home with long-term care and also with special care units for persons with dementia. And we had two parts. The one was a mapping of the frequency and reason for it and so on, and what type of coercive measures. And the other part was a qualitative interview with staff and with doctors and so on. And what I present now, the results, is from the quantitative part, which I had responsibility for, and it will soon come papers about both these parts. What we wanted to look into, what happened if a person resists care. So we asked through all the patients with staff who had at least one episode who they resist care during last week. And we looked further into them. So that's, and we see here, no, I have forgot to press her here, but I said it. I go to my notes and then I forget it. But what we see is that the upper table here is the long-term places in beds in the nursing home in Oslo, special care and strengths and special care units, and how many patients and how many and the amount of places. Antal plasser is beds. And the lower is who we looked at, and we see that we had a sample of 506 patients that we get into detail. So it's not mapping of all the patients, but there's a selection. of 506. And we also see that about half of them were in special care units, but only 1/4, 25% or 23.1 of the beds are in special care units. So we have to do some weighting of the numbers afterwards. And here, very short, the results. Here we see that 208 patients in the red number there, they resist care. So that's 41% of all the patients had at least one episode where they resist care. And that's quite many. But as you see, if you see performing care without force or resistance, that means that the staff have been able to carry through the necessary care without use of force or pressure. So they have built some trust or confidence with the patient and managed to do it, even though they didn't, even though they resist. And that was the main number. But you see that the sum of the red numbers there are more than 100%, and that's the percentage of the 208. And that's because some you manage sometime, but sometimes you don't manage to do it. So then you have to use force maybe 1 or 2 times, and the rest of the times you manage to do it without use of force. So coercive measure or use of force or pressure is 45 out of those 208, and that's a little bit more than 20%. And undone care was also quite often. That means that they didn't do it. If they have to change the diaper and the person resists, they don't just skip it. So that was an easy way maybe to handle a situation. And we also see here that the light green to the left is legal processes. It's 40 patients that had a decision that they could use force or pressure if necessary, if it was necessary. But, and the dark green to the right are patients who they actually used force or pressure at least 1 time during last week. And we see that not 100% overlap. Half of those patients who had the decision, they didn't use the decision last week. And more than half of the patients who they have used force or pressure have no decision on it, no legal process. So that's outside the process. And no, also low grade of documentation of these patients. So that means that at least 68 or 13.4% of all the patients, they had either a decision that you can use coercive measure or it have been used. What we see here is what kind of coercive measure is used. And you see that in care situation with hygienic care or other hygienic measure, for example, changing a diaper is the most often used situation where it's used. And I also highlighted the mechanical or physically restrained because that's are nearly never used. It's 3 patients it has been used for. And all these have a decision that it was necessary. So what was the most common measure 20 years ago have nearly disappeared. Very seldom that people are fixed to the chair or other physical kind of restraints. So that's at least a positive development, maybe as a result of the law. Something else I wanted to say? Yeah, and we also see it's 45% of the 45 patients this is about. So this is then 8-9% of all the patients that have some kind of coercive measure. In year 2000, it was 40%. So it's a it's just a fragment of this kind. So what we see is that it had been a change from resistance to care, and we hope that this change is that most situations are building confidence with the patient or building trust and manage without use of restraints. But what is this kind of measure that mean that we handle it? And I think that's what Stefanie told about in the first speak here, that we see that you have to build the competence of the staff, you have to build up the ability to communicate. Communication is very important, and have a good atmosphere, and so on. So I think that it's very important to see what we are doing there. But the most often thing they did was they just waited to see. So they just postponed the action, the hygienic and so on. And in the quality interviews, we see that they are very discussion, how long should we wait before it is undone care? Or they just try with another carer. I didn't manage to change the diaper, so you have to try. So it's not that very advanced caring that is that in communication and so on. So I think that the first speak here is very important. So how to raise the staff's knowledge and ability how to handle this without of using coercive measure. And we also see that undone care are quite often. And is that a good thing? And what is coercive measures also? That's a very difficult borderline, a gray area between building confidence and coercion, because it can be that you try to make some mild pressure and do something that maybe we do in all life between us all together. When I speak to someone, I put some pressure on people to do something, and very mild pressure. Is that then coercive measure? So it's not all clear also when we count. And we see that coercive measures are more used among persons with dementia. Nearly all of them, I think all of them had a diagnosis of dementia. So it's absolutely a dementia topic. Thank you.
Thank you. Thanks very much, Øyvind. Øyvind literally has to fly, so there won't be time for questions for him, unless there's a very quick one that you want to take. Is there a quick question? Just the one. I'm afraid just the one question.
You acknowledge that obviously the practice of kind of physically restraining someone to a seat, that seems to have declined. I found that really concerning that still your findings are showing that restraint and kind of those controlling measures are still happening in practice. And although you link the chair restraint to possibly the legislation coming into place, do you think this is a lack of awareness of people knowing that they are restraint procedures still? Or do you think that if legislation came in, that this could be rectified?
Well, my hearing is... I'm not sure if I heard your question good. My hearing isn't that good about.
Could you repeat it again? Sorry.
So you acknowledge that people being restrained to chairs, you didn't see that so much in your data. So when you did your study, that isn't happening so much. And you linked that to possibly the legislation changing, so law coming in to stop that from happening. But what you also highlight is that there is still a lot of restraint practice happening in care, and that's quite concerning. So do you think legislation could change that, or do you think this is an awareness and training issue amongst staff?
I think that a lot of situation, it could be handled without the use of pressure or coercive measure. And some of them are quite well-reflected situation, so we have both. But what we saw that the lack of the legal process was that they think that that process was very demanding. that from the qualitative interviews. So they think that it's difficult to go into that process. They need a lot of documentation and so on. So they just carry through what they think is good care.
Okay.
But then we lack the documentation, we lack the rationale behind what they're doing and so on. So it's very difficult to know if this was a good care situation or it was unnecessary use of coercive measure. So, but we also see in the interviews that it's very, very different culture from ward to ward.
Okay.
And it's the level of knowledge. And we have also in some of the nursing home a language problem with the staff, that some of the nursing home have a high level of staff that are not that good in Norwegian. So I think that's also a thing we have to look into.
That's fantastic. Thank you so much.
Okay, thank you very much. Øyvind, thank you. All right. Could I invite Zena to the stage? Zena Aldridge is going to talk to us about a very emotive subject in terms of end-of-life care and the courageous decisions that perhaps need to be taken. Zena, over to you.
Thank you. Zena Aldridge, I'm a dementia nurse specialist by background. I was very fortunate to be able to undertake a PhD supported by Dementia UK with the research question very much driven by my own clinical practice. What I wanted to explore was the experience of nursing home staff when providing end-of-life care for people with advanced dementia, particularly when they were showing signs of deterioration. I'd worked in various areas across our health and social care system, was becoming increasingly aware of the disadvantages affected by people who were living with advanced dementia in terms of their ability to access mainstream palliative care. In the UK, in excess of 80% of people living with advanced dementia either die in care homes or in hospitals. They don't die in hospices, they don't die in their own homes, and they often do not have access to appropriate palliative care support. So my view was actually if nursing home and care home staff are providing the majority of end-of-life care, how does that affect them and how do they cope with that? And what I'd like to highlight is this data was collected before COVID. I'd like you to bear that in mind because actually when you see the impact that it had before COVID, I think you'll understand why it feels really emotive now. So data was collected by interviews with 28 participants across 3 English nursing care homes, all different providers, different sizes, and in very different areas. All, though, had a primary focus of providing nursing care to older people. So I wanted to understand what motivated their decision-making when someone deteriorated, and one of the reasons behind this was the fact that actually prognostication and trajectories in end-of-life care for people with dementia is really complex, and often people are not particularly confident or competent in identifying when someone might be coming to the end of their life. And to consider how this impacted on the nursing home staff who work in a very person-centred relationship model of care but are often having to interact with health clinicians who work in a very medical model of care, and that conflict arises when there might be perhaps 2 dichotomies and although the end game might be that they want the best for that individual, what the best might be can be perceived very differently in those 2 areas of practice. So as a nurse, I don't know many nurses that work in our national health system in the UK that would take a set of keys to look after 60 to 70 very frail, complex older people on their own with no medical support or clinical supervision within the building. If you're in a hospital, you'll have a bell where you can pull for support if someone deteriorates, and within minutes you can have doctors and therapists and everybody else coming to support you. But in a nursing home, that's not the case. You might be the only nurse on duty on your own with unregistered staff. So it's a really challenging area of care. What was really important to all of the care staff, whether they be nurses or whether healthcare assistants, was they wanted to facilitate a good death for their residents. These were people that they had developed relationships with, they cared, they'd built attachment with, and in many cases they said they loved them. They were like members of their family. They'd known them for many months, many years, and so the care that they delivered was personal. And they were absolutely clear on what that motivation was going to be. But it was also about how did that affect them? Because actually, if you're caring for lots of people who you feel attached to, who you care for, and you're constantly exposed to dying and seeing them pass away, that takes a toll. A lot of nurses who work in specialist palliative care services get clinical supervision and all those kind of extra wraparound support in acknowledgement that they're exposed to death and dying on a regular basis, but care home staff don't necessarily get that kind of support and supervision. So what I found was really key in motivating their decision making was a moral compass. They all had their intrinsic moral compass of what the right thing to do was in a given set of time. Now, when we were talking about deterioration, that in itself created some complexities, because I went into this thinking we were talking about a physical deterioration. But actually, for the care home staff, a lot of the time it was more about the emotional, psychological, mental deterioration that they would often see well before the physical deterioration occurred. This then created a tension because actually someone might physically deteriorate and the doctors might say, well, actually they need to go into hospital. But what the care home staff were intrinsically aware of is if they went into hospital, it was likely that their mental health, their mental well-being, their emotional well-being would deteriorate. And actually to them, that was more of a challenge than actually managing the physical deterioration in the care home setting. So it was about understanding what do we need to do for that particular individual at that point of time. And there were kind of 4 key pieces of information that the care home staff wanted to understand in order to inform their decision making. So it's about knowing and seeing the person, not seeing the diagnosis, but seeing the person, seeing them as an individual in the context of their lives. It was about trying to find out their wishes and preferences. And of course, when we're talking about advanced dementia, very few people have advanced care plans that have been able to, that they've been engaged in developing earlier on in their disease progression. So finding out wishes and preferences was about talking to families, getting to know from the families, trying to pick up on those cues and clues from the person living with dementia. And even those in the most advanced stages, when it came to kind of resistant treatment and things like that, they might almost indicate that enough was enough. It was about using their prior knowledge and experience of what the process might be if they raised concerns, what might end up happening, because often in the UK, if care homes raise a concern, they might have to contact an ambulance, for example, and without that advanced care plan, the person with dementia might be taken to hospital, even if they think it's not the best thing for them. But one of the things that was really, really resounding was that the care home staff prepared for the inevitable, and the inevitable then was that people were going to die. You know, they were looking after people who were coming to the end of their life, whether that be in the next 12 months, 18 months or 2 years. So they knew that they were caring for people in that last part of their life. So they weren't shocked, they weren't surprised, but they were planning for it and picking up on those cues and clues about deterioration. The staff actually had a real strong perception, whether this again be healthcare assistants or whether it be the nursing staff, of what a good death looks like. And actually, you'll see that if you look at the concepts of a good death in palliative care, these are resonating quite clearly. They're not different. So it was making sure that the person with dementia wasn't alone, that they weren't left alone in those last days and hours of their life, and that someone could be with them. And the staff were really challenged when they weren't able to sit with someone for whatever reason, and that was really an issue for them in terms of distress. They didn't want people to have futile treatments. They didn't want people shipped into hospital for rehydration and antibiotics if they thought it was going to be futile, because they could see that that was not going to be in that person's best interest. They wanted the person to be cared for in a place where they felt safe and where the staff knew them. And time again, the staff raised concerns about how they perceived the treatment in hospitals, not because it was bad treatment, but it was being delivered by people who didn't know the individual and their individual needs. And they didn't want to see the person in pain or distress. So if a decision about what needed to happen when a person deteriorated was in line with their moral compass, they were fine. They were absolutely, you know, they experienced moral well-being. They felt that actually it was a job well done, that the person had stayed where they wanted to be, they'd been looked after, and that wasn't a challenge to them. There was no moral conflict there. But actually, if the decision made by the clinicians who might come into the home or by others in the MDT were there, they would say that they would feel moral resignation if the decision made wasn't necessarily the best thing, but the person hadn't come to harm. But if it was in contravention of their moral compass, they were morally distressed. So they used moral courage, and they used moral courage to challenge decision-making if they thought it did contravene with their moral compass. So what you'll see a statement there from one of the nurses, I will do it, and then if you want to challenge me and take me wherever, whether that be to a tribunal or complaint, I'm quite standing up and saying why I did it. And that was again about adhering to that moral compass, making sure that that person was going to have a good death. They could do this through challenge and negotiation, so being morally courageous sometimes meant challenging other clinicians who might come into the nursing home. They might challenge with the GPs and say, no, absolutely not, we don't agree with this, we think there's a better option. And you can see here, one of the nurses, all they needed was a doctor to come out and change a dose of morphine or midazolam or whatever the resident was having at the time. They rang me at home. This was one of the nursing home managers who's also a nurse. So I did it from home. I said, no, we are not going to give up. And I rang from home, and within 10 minutes, a paramedic crew arrived. As it was, the crew on board were able to change the medication, so she was fine. You have just got to be determined. And this was in a situation where a GP was trying to admit a patient into a hospital without actually seeing the patient, but actually it was just a medication issue that needed to be resolved. Another nurse at the bottom there, and actually I said to this nurse, what do you think if would have happened if you hadn't challenged? And she said, I think potentially the resident, would have suffered. Once you've done a few years of this, you get a bit gutsy, don't you? And I say, no, I'm not taking this. Occasionally, though, the nurses had to resolve to rule breaking, and that's when actually a procedure or policy didn't fit what was morally right for that individual. And you'll see here some of the nurses saying, if we need to do things, I will take responsibility under the Nursing and Midwifery Code of Conduct. When it goes right, nobody says anything. But if it goes wrong, everyone wants to blame you. We do what we can. And one of the challenges we have in UK nursing homes is if someone's paid for residential care, not nursing home care, any changes in medication or administration of end-of-life medication needs to be done by a district nurse who could take several hours to come to the home. And here you'll see the last comment there. We had it recently where someone who was a residential bed became terminally ill. So we got all the anticipatory meds in place. We phoned the district nurse and they said, we're going to be with you in 2 hours. I'm not going to leave that person in pain, so I gave her the medication. Who's going to argue it? The family are not going to argue it. If anyone does argue it, we can say we did it in the patient's best interests. It's not like I'm overstepping the mark as a nurse, because all my nurses are qualified to do. It's just literally essentially a tick box on a piece of paper. But actually, that nurse did put herself at risk potentially because she had overstepped the mark in terms of what she was being commissioned to do for that individual. But it was they were actually happy to do that because they could not sit and watch someone die in pain when they had the skills and expertise to deliver that end-of-life care. When they used moral courage, they felt that they'd done their best. They'd done everything in their toolbox to try and make the outcome as positive as they could be. So again, if that moral conflict was resolved and they felt that they'd been able to challenge and got the outright outcome for that individual, they then had moral well-being. But again, if they'd come to a compromise and the person hadn't come to harm, then they would actually say, well, it's moral resignation. It's not what we would have chosen to do, but it's not actually the worst thing in the world. But what it did show was that when the outcomes didn't meet with the individual's preferences and they didn't think that the resident had a good death, they experienced moral distress. So by using moral courage where they could reduce the incidence of moral distress. And hence I say to you, please refer back to the impact on care homes during the COVID pandemic, when many care homes lost sometimes in excess of half of their residents in the space of a week. I can't imagine what that would have been like. So conclusions, this study has demonstrated that moral courage could be used as a tool to reduce moral distress in nursing home staff when making decisions about end-of-life care. We do need to think about the concept of deterioration and what that means in different settings, because often we get told that the soft signs of deterioration are those that are seen in nursing home care, but I would argue they're very skilled signs of deterioration. And it's highlighted the novel concepts of moral well-being and moral resignation as opportunities to reduce moral distress in people. And thinking about how medical and biopsychosocial models connect. There's a reflective discussion tool available there that enables nurses to reflect on these incidents after a death, to think about how they could change practice. So by reflecting and learning, they might be able to change outcomes further on. So thank you.
Thank you. I must be rubbish at this job because we're going to run over, but I will take one question for Zena if anyone wants to ask one. Could we just take that one question, please? Do you mind?
No, not at all.
We will run over by 5 minutes. I apologise. That's my fault.
Hello. Thank you very much. This was a great presentation and such an amazing research. Early on, you mentioned among the factors that nurses considered the most important, the reconstruction of the will and preferences of the patient or the person, better. There is of course, quite a lot of debate in the ethical legal literature over whether that's a utopian kind of concept, especially towards the severe stages of dementia, which I guess are some of the most frequent situations for obvious reasons. Yeah, and people say, oh, it can't be done, or it's too uncertain, or you can never be sure. So what would be your message in relation to this debate?
I think there's something about, ensuring that we look more at advanced care planning earlier on. Because actually then we could reduce the incidence of having to predict what people's wishes and preferences might be and open up those conversations. Certainly on transitions to care homes, I would say actually asking someone what funeral director they want and things like that is pretty irrelevant. It would be more better to ask them what they might want if they deteriorate and approach their end of life. And build that confidence and competence amongst the workforce. And I think there's something to be done in primary care where we get clinicians to start preempting and having these conversations earlier on as well, because I work with a lot of healthcare professionals who do not know how to prognosticate someone who is perhaps frail and living with advanced dementia, and so they don't have those conversations in a meaningful way. But often just speaking to the families, and actually, yes, someone might not be able to communicate as articulately as they once were, but you can try and communicate. You can try and get that information. You know their body language, and I think by knowing the person, you start to build up an understanding of what their wishes and preferences are. So I think for me, it's about using those all in conjunction, but the key is relationship-centered care. That's what it's all about.
Yeah, but so they had the feeling most of the time that they knew what direction.
Sometimes they didn't. Sometimes they were saying that sometimes she goes, sometimes you have to do what you think is right and hold on to that. Yet we don't want this person dying in pain. We want them to, and how that person would have wanted that, they may not know intrinsically, but they would just went, by the grace of God, was a comment used a lot. We do what we think is the right thing. So it's about holding on to that moral compass.
Brilliant, thank you.
Thank you. Thank you very much, Zena. Could I have another round of applause for Zena? And the next person we're inviting to the stage is Angela Gregory. So Angela's going to talk to us about meaningful interactions and meaningful activities in care homes. There you go, Angela. Thank you. Welcome. Could we welcome Angela?
Thank you.
Thank you.
Can everybody hear me okay? Yeah, great. Thank you. I've never used one of these before, so I'm not quite sure which one to press. I assume it's the green one. Thank you. So welcome to this talk, and thank you so much for staying. The talk is about meaning in meaningful relationships and activities with people living with advanced dementia who live in a care home. So my name's Angela Gregory. I'm currently a PhD student. I'm an occupational therapist as well, and I have a background as a freelance artist. Today, I want to spend the majority of the time talking about the people that I worked with. So if you have any questions about the theory or the references, feel free to ask me afterwards. But I just want to celebrate the people. I want you to come out of here inspired by the people that I worked with. And there's my tweet, if you would wish to tweet me. So I'd like to just tell you what the presentation is going to be about. So I'm going to unpick the meaning in the term meaningful activities. I'd like to share my findings, as I said. And I also want to highlight the importance of directly involving people living with advanced dementia in research. So the term meaningful activity is widely used in care homes, but little is known about what the meaning actually means, particularly for people living with advanced dementia. In general terms, meaningful activities include everyday activities like washing and dressing and eating, as well as leisure activities and work. Taking part in activities like these can help us to feel happy, satisfied, and in control of our lives. And when living with advanced dementia, the person is likely to need a care partner for all activities and also to communicate their preferences. And also, they may have reduced opportunities to take part in activities, and they could become depressed and withdrawn. Excuse me. So when I searched the literature on this topic, most studies were about measuring outcomes. And they looked at activities as interventions. So they didn't particularly focus on the meaning. I think there were 18 studies in the end that I chose. Only a handful of research included people living with advanced dementia, with most focusing on people living with mild to moderate. And this was due to assumptions that the person didn't have capacity to be able to partake in research, or because of lengthy ethical procedures. And some studies included people living with all stages of dementia, but then they combined them in their findings, which made it really hard to understand the implications for people living with advanced dementia. And sometimes studies often did not adapt the methods. So if they did include people living with advanced dementia, they might use something like focus groups, which relies heavily on verbal skills. So that left an opening. Oh, I didn't do that, did I? Sorry. That left an opening for my own research. So the project was an action research study, which is a cycle of looking, thinking, and doing. And it's about researching with people, not on them, to create change. And as represented in the slide, I completed one cycle of action research with 3 phases. The first phase was about a shared understanding of meaning. Second phase was exploring the meaning, and the third phase was consolidating and reflecting. So I worked in one care home for 6 months with 4 people living with advanced dementia, 4 of their family members, and 6 care home staff. And I used video to collect the information. And my findings included recognizing meaning, mutual awareness and reciprocity, an appreciation of the ordinary, and the importance of being in sync with the person during partnered activities. So the next slides I'm going to show you are stills of video stills from the study of participants. I have permission to use them, and any names that I mention are pseudonyms. So understanding the meaning in meaningful activities with people living with advanced dementia was partly about recognizing the person's individual ways of communicating, which I think the others have touched on. So some people might speak just a few words, Other people might speak in full sentences, but the context might be difficult to understand. So it was really important to listen in a different way. Watch how the people use their bodies, how they use their voice, the different tones that they might use, and looking at the facial expressions. So each person used their body to communicate. And sometimes this was really subtle, so it might be a raise of an eyebrow, or a slight smile, or a soft touch. Other times it was really explicit, like dancing and walking away. And in the picture here, you can see Morag. And Morag is a 91-year-old retired cleaner and car inspector. And as far as I was aware, neither of us knew how to play the drums. I didn't want to limit the activities to past activities and past interests. I think we're always changing, we're always learning, and I don't necessarily like things that I did 10 years ago personally. And I'm not saying that the past isn't important, it is. So I brought a drum to Morag to see if she wanted to have a go. And she moved her fingers in a drumming motion and smiled. So that was her assenting, telling me that she wanted to try. So we began this conversation through rhythms, and it was like a call and response conversation. And although she was able to tell me that it felt great, she did this with her body as well, when she experimented with the drum with a look of concentration. And at one point, I asked if she wanted to finish or carry on. And without words, she continued playing, indicating that she wanted to continue. And after a short while, she slowed the rhythm down, as if ending the tune. Then she stopped, looked at me, and grinned. Being aware of one another, and this goes back to your work, Zena, as well, about really seeing the person. And I don't mean just looking, I mean really seeing them. Being aware of one another and acknowledging this awareness was important for meaning making during one-to-one activities, because it reinforced and validated the person's existence and their visibility as a person living in the care home and as a person generally. And that opened up opportunities. So reciprocity is a difficult word to say, can be subtle or it can be more obvious, but it wasn't always what it first seemed. So in the picture you can see here, there's a staff member who had set up a working train set for Donald, who was an 83-year-old retired ship welder. And the staff member herself, the sounds and the movement of the train provided opportunities for interaction and reciprocity. Another example is when I was with Donald and we were walking together down a corridor and he wanted a little break, so we sat down on the sofa. I started chatting to him and he just stood up and walked away. And I'd previously been told that that meant that he didn't want to be involved anymore, but it didn't feel like that when I was with him. So I caught up with him and I asked him, "Is it okay if I join you?" And to my surprise, he looked at his arm and did that kind of movement and said, "Hold on." So I took him up on his invitation. We linked arms and he took me on a tour. He became a tour guide and he took me on a tour of the care home and the care home gardens. And the participants living with advanced dementia showed an appreciation of the ordinary, the things we miss. We're so busy with the things that we walk through and we miss. And it was really important to be open to exploring this with the person and to be led by their curiosity. Fraser, an 84-year-old retired retail manager and staff member, and Judy, a staff member, were walking down the corridor through some double doors, some automatic doors, when Fraser wanted to explore a sticker on the door which said "automatic fire door." So he showed his interest by stopping, looking, and touching the sticker. And he really studied it. And the staff member noticed his interest and paused. And after a few seconds, Fraser removed his hand with a little purposeful and satisfied kind of flick. And he still intensely looked at the sticker. And the staff member read out the words on the sign, and then Fraser responded by saying "automatic, in a rhythmic way. So having purpose and small goals in the moment was important. And if the staff member had overlooked this and not seen the value in exploring the sticker, he may not have had the opportunity to feel it and study it. Being in sync or in tune with the person was meaningful because it could create a sense of connection where each person's skills could come together to achieve a small goal. So matching the person's pace during the activity, and this wasn't always about slowing things down. Donald had me walking extremely fast. And being in sync could be transient, but it could also then return. So Hamish here, a 91-year-old retired salesman, and his daughter Susan can be seen dancing. It was one way that they communicated that didn't require words, and it gave Hamish an opportunity to move his body and express how he felt, which he showed by using sophisticated hand movements and facial expressions. And together, Hamish and Susan became merged with the music, and Susan described the meaning as beautiful. Through the music, Hamish was reconnected with himself, his daughter, and a pre-loved activity. So just a consideration. So I used a wearable camera and an iPad to collect the data. And one consideration when using the equipment, which reflects a person's physical image, is to understand that they may be very aware of how they usually look, and when they see their image, they may be shocked if it doesn't match this, as in the scenario here. But what it did show was that people living with advanced dementia may still have pride in their appearance, and that objects like dentures may be really important for dignity, self-esteem, self-awareness, and familiarity and sense of self. So after all this talk about meaning, what is the meaning? So meaning in meaningful activities and relationships with people living with advanced dementia was unsurprisingly individual to the person. However, there were common elements. So it was about purpose, curiosity, small goals in the moment. Meaning can come and go. It can reoccur or be revisited. It can occur in activities initiated by the person or created in partnership with others and/or objects. Meaning can be created through mutual awareness and reciprocity, and understanding the person's responses may help to guide and inform an activity partnership. Activities and interactions that reinforce the person's sense of self can enhance meaning, but also meaning can be easily missed and accidentally overlooked, requiring others to be sensitive to and appreciate the everyday. So just to finish up, the painting that you can see, I did 4 paintings, 1 for each person at the end of the study, each person living with advanced dementia, based on the time that we spent together. So it's really important to unpick familiar terms and not assume that we know their meaning just because we use them all the time. It's important to be sensitive to the ordinary and really look and absorb what is around us in our environment and notice the person and what they're interested in. And people living with advanced dementia can actively participate in research. It's researchers and methods that need to change to make this accessible. Methods and researchers need to be flexible, creative, and adapted to the person in the moment. We cannot gain a full view of the experiences of others without including them, and they were absolutely crucial to this study. I've done it again and not clicked on the thing. Thank you very much for listening.
Thank you, Angela. Have we got one quick question? Anyone? Well, you're escaping. I don't know if anyone noticed, when she started to talk about dancing, she started swaying. Thank you very much, Angela. Okay. A theme that's running through all of this, isn't it, that is about valuing the person, whether they have dementia, whether they're at their end of life. It's about valuing the person and doing the very best you can for that person. And that can be in a care home, it can be in a residential setting, or in their own home. But it's about valuing the individual and what is important to them. Anyway, Alan, over to you. Alan Berraud. Berraud? Berraud. He's going to tell us about new homes for people living with dementia.
Thank you. Ladies and gentlemen, good afternoon. As you suspect, I'm not Christine Tabuenca. Finally, she can be here to do the presentation, and she's so sorry, but I will do it. My name is Alain Berraud, and I have the pleasure of talking to you about homes, French homes, specifically dedicated to people living with dementia. In France, the elderly have two main choices of place to live: home, whenever it's possible, or nursing home when disabilities are significant. And an alternative is currently being developed: shared homes. Homes where several residents live together with shared areas, such as living room, dining room, and private area, for example, bedroom, and collective services, laundry management, and meals preparations. These are homes, not accommodation establishment, where you can have safety procedures, safety protocols, safety standards. Most of their homes are for frail elderly people or those with disabilities. But homes specifically for people living with dementia are few and not well known by general population and professionals alike. Here are some characteristics about shared homes. Information comes from a qualitative observational study conducted in 2022-2025 in 6 specific homes for people living with dementia. The first characteristic is shared homes accommodate 8 residents and in a proportion of 1:1, 8 home support workers. They help with daily living, they maintain home, they lead and organize activities, sporting, cultural, or simply outings to the town. And it's very important, in one of the characteristic of shared homes, the presence of professionals is 20 hours a day. And at night you have a home support worker on site. We have another professional, a housekeeper. She's managed community life, organizing different activities such as shared homes council, which bring together residents, families, and professionals. She coordinates the intervention of outside professionals such as medical doctors, nurses, physiotherapists, and so on. And finally, it's very important, she is the point of contact, not only for family, but also for all external professionals, and especially the funders. So, homes to do what? Here are objectives of the Living Project. The first aim is to maintain the abilities of people living with dementia by involving them in the organization of daily life. These include domestic tasks such as doing shopping, preparing meals. The principle of action is doing with rather than doing for. And the second principle is to avoid any situation where you were set up to fail. The second way is by living in the community. Despite the difficulties due to the disease, residents respect certain social norms, making sure to be presentable, dressed, clean, and sometimes wearing makeup before entering in public areas. Living in community means being subject to the gaze of others. Another objective is to build a community life. And it means striking balance between individual freedoms and the rules of living together. Residents can wake up or go to bed when they want. They can choose whether or not to take part on activities group. The second point is safety. As you can see, all dangerous objects are kept at distance or locked away. For example, the laundry room is locked in order to limit access to cleaning products and detergents. Another safety way is to close entrance doors and gates. And the last point about safety, as we have seen, we have at night a professional and sometimes a student tenant can also help out the home worker support. Another objective, encouraging community life. Moving into a shared home is not the choice of the resident, but the family. And for those with spouses, the separation is painful. So, community life has to bring joy, pleasure, entertainment in order to counterbalance the feeling of loneliness. Some special feature, meals. Mealtime usually is a convivial time, but it can be a burden for residents and professionals. As the day progresses, tensions, bad atmosphere can build up. And that can lead to dinner during which residents can express their frustration, and you can have competition for each other's attention. So, meals need to be facilitated by home support worker or a volunteer. So you can speak Old French, jokes are told, songs are sung, and sometimes some episode of the history of the town are recalled. It's possible to dine in a small group with affinity, but the best solution is when you have an outside guest, because this person generates interest and brings new topics for discussion. About activities. Activities can consolidate the group spirit. You have spontaneous activities. Hey, what about an aperitif before the meal or a coffee session after the meal? You can play board games, walk in the garden. You have also scheduled activities, art therapy, physical activities, adapted gymnastics, and as well, cultural sporting outings. It's important for these shared homes to be open to the city. That's why shared homes are usually located in town center. As the disease progresses, functional difficulties will appear, as well behavioral problems. And it's possible to put in place, thanks to the intervention of outside professionals. And if it's necessary, you can organize hospitalization for assessment and treatment. However, the bed remains reserved for the return of the resident at home. Maintaining family ties is very important activities are organized with the participation of families and friends. It can be cooking workshop to make a birthday cake. You can prepare a Halloween party by creating decoration, creating fancy dresses, and organization of makeup session. It's important to foster closer ties between residents, to build solidarity between families. And discussion group and video meetings organized by the housekeepers contribute to build solidarity between family, group spirit, and peer support. And solidarity continues right up to the last moment, as it is possible to choose to die on site. And families will support the bereaved family. And it's interesting to notice that several volunteers are relatives of deceased residents. After this idyllic presentation, some few points to be aware of. The first one is the risk of selecting residents on the basis of their family background. In fact, if you have no family, you can't enter in these homes. The second point is the varying level of family involvement. Family is responsible of care and cure provided to the resident. So you have a wide variation between residents. Organization of community life have we seen, living in the share home is not a choice, and the level of integration of the resident can vary from a resident to another. Housekeeper is a job still being defined. The perimeter of her duty is not stable. There is no initial training, and about knowledge about Alzheimer's disease and related disorders is insufficient and often inadequate. Concerning home support workers, they tend to favor domestic work over relational work. And finally, the most important, the economic model has not yet been found, and it's a major obstacle to the development of this type of homes. Thank you.
Is there a question for Alain before we draw a close to this? Yes, Angela?
Hello, thank you for that. I just wondered, when you said that you're trying to reduce the risks and having kind of things like cleaning products away and locked away, I wondered if there was a more kind of almost reablement way of doing things, as in having cleaning products that weren't harsh enough, with kind of more natural products, so that people could access things and be increase their independence.
It's from a new study. I haven't got the data. Yeah, not yet. Yeah, next year probably.
Listen, thanks very much, Alain. And could I ask you all to thank our presenters again today, and thanks very much to you for staying with us.